Good evening, everyone. My name is Dr. Barry Bittman. I'm the Chief Population Health and Quality Officer for the Inland Empire Foundation for Medical Care. And it's my pleasure to present this program to you this evening, which I believe is of utmost importance for all of our providers in this region. Please know that this presentation is only a guide. Everything is changing rather rapidly in this quickly evolving healthcare emergency that we're facing. And we hope to be able to update you on a regular basis on those aspects of care and recommendations that change. Before I actually get started with the presentation, I'd like to emphasize the fact that there is a COVID-19 Tools and Resources Kit that can be found at rcmadocs.org/COVID-19. This provides the additional information that you will need to make the best decisions for your practice. I'm going to refer to that set of information multiple times this evening. Frankly, these are difficult times. What we're facing now is truly unprecedented. In my career as a physician, 43 years, I've never faced this type of challenge before. However, I am confident that working together, we can get through this. The bottom line for our focus this evening is that you should not shut down your practice, yet you have to maintain a level of care that ensures quality care for your patients and at the same time safeguards the health of your office staff. We need your ongoing service and expertise, and your judgment and your experience are basically what's going to carry us through this enormous challenge. When we think about our present state, I can tell you that a great deal of work has gone into trying to figure out the best strategies to deal with an unprecedented virus. Recommendations, as I mentioned before, are likely to change, and we receive input every single day from multiple sources. Despite those recommendations, I'd like to tell you that your judgment should always be prioritized. There is no substitute for physician judgment during an emergency situation like this one. Our goals are pretty straightforward. We want to make sure that our practices can optimize care for those in need. We especially want to prevent bottlenecks that occur at both the emergency room and in the hospital. What's really critical at this point is not losing sight of the needed non-virus related healthcare that we're all used to providing. And finally, and perhaps most importantly, in the context of keeping us on the front lines, our goal is to help you safeguard the health of not only your providers, but also your staff. Without you, this can be enormously difficult. I want you to stop for a second and read this sign. If you believe you have coronavirus or have been exposed to the virus, have traveled to a high-risk area, or if you have symptoms like cough, fever, or shortness of breath, do not enter. Please return to your car and call our team. This is where you insert your practice's phone number, and we will help you with what to do next. This is a sign that we are asking you to consider printing and placing on your office door. The most important aspect of this approach is not to bring people into your practice who have symptoms as well as those who are asymptomatic. Based upon the curves that we are seeing in the rapid rate of expansion of number of cases, it is highly probable that 50 or 60% of our cases are being transmitted by asymptomatic hosts. At this stage of viral advance, it's fair game to believe that everyone is potentially infected with the virus. So whether you elect to allow individuals without symptoms to enter your waiting room, the bottom line is that those individuals could spread the disease in a closed space. What we really have to think about in terms of this virus and this challenge is how we can best reorganize our workflows in order to ensure our goals. First is to consider posting that sign on your door. And by the way, that sign is available on our website in both English and Spanish. Second, establish a team within your practice. The majority of your providers and support staff should work from home. You only need to man your office with a skeleton crew, perhaps clerical support, a manager, and perhaps one provider if possible. Of utmost importance is to schedule all routine office follow-ups, including non-COVID-19 visits via telehealth. And you may be surprised by this recommendation, but the bottom line is that many successful practices in our country have been seeing more than 60% of their follow-ups through telehealth over the last few years, even in the absence of this type of emergency. The key here is not to expose your patients unnecessarily to a waiting room with both symptomatic and asymptomatic carriers. Next in line is keep all telephone lines open for patient calls. That becomes your nerve center, your communication center, your link with the outside world. Be careful to maintain one line, it could be a cell phone if necessary, for communications between your office staff and your providers so that they can relay information pertaining to the conversations that they conduct with your patients via phone. It's really important that all providers, whenever possible, maintain remote access to EMRs. Now, I know what you're probably thinking. My EMR doesn't allow me to do so, or I've never done this from home. Bottom line is, let's follow the advice of Anthony Fauci. Let's do the best we can with what we have. If you're unable to document in your EMR from home, paper is the next best thing. So don't not offer telehealth visits because you don't have access to that EMR. Let's talk about our triage strategy. A lot of the information that you see on this page may be known already by your practice. Many of your office workers and staff know your patients very well, so all of these questions do not have to be asked. But the bottom line is, you want to know whether or not the person has been in contact with anyone who's tested positive for a virus. And you want to review at least some basic symptoms that have been formulated based upon reports that we've received from around the world. Again, this is early and data is not in, but the important ones seem to be fever, chills, myalgias, the complaint of stomach ache as an early symptom, of course, cough, chest pain, difficulty breathing, dyspnea, severe headache, weakness, confusion, fainting, alteration of consciousness, and what we've learned in the last 48 hours is diminished or loss of smell or taste. These seem to be early symptoms of COVID-19. Another open-end question is just to ask the patient if they're experiencing symptoms that you have not asked them about. This is especially valuable given a history of asthma, COPD, breathing disorders, cardiovascular disease, heart failure, diabetes, chronic kidney disease, end-stage renal disease, cancer, or immune disorders. And it's essential that you know whether or not that person is immunocompromised and presently under treatment. It's also important to know how long your patient has had these symptoms, whether they're progressing, and their age. Their age seems to be important because the majority of patients who have succumbed to this disease are over the age of 60, although there are reported deaths in younger people and children. There also seems to be a predilection for men, and the ratio is roughly 60 to 40, 60% men and 40% women. These statistics don't really help when you're looking at one individual, and we will be able to refine that information and that advice as we proceed through this crisis. I want to emphasize that there is nothing more important than your medical decision making. Clearly, individuals without known exposure, fever, or respiratory symptoms should not be referred for testing or evaluation. However, there are always exceptions, and no two cases are alike. So use your discretion as a provider. Your experience, your knowledge, and your wisdom are key to dealing with this successfully. Be absolutely certain that you focus on individuals who may be in an immunocompromised state because they're at higher risk for poor outcomes. I won't mention these disorders, you can read them, but the bottom line is for these individuals, further evaluation or testing is warranted. And I'd like to share a bias at this point. Given the lack of PPEs, personalized protective equipment, I don't think that every one of you should be testing patients either in your offices or your parking lots. Our recommendation is that if a person requires testing, you should send them to a local center, and we're going to give you information on where you can find those testing centers in your area. What's really important here is that if you have an individual who you know has been exposed or laboratory confirmed and who is febrile with any combination of symptoms, and what I'm really talking about is in terms of the ones that were noted on the prior page, you should appropriately assess that individual and make the decision of whether or not to perform a telehealth consult, send the patient for testing, or direct the person to the local hospital. And I'd like to comment on that as well. Most hospitals in this country have set up their biohazard tents outside of their emergency rooms to do screening and triage. This is a great opportunity to have these individuals screened so that we can prevent extending those infections into the hospital itself. It's your decision, but again, you should consider telehealth, referring the patient for testing, or directing the person to your local hospital. The issue I think that has changed the most in the course of the last week is the use of telehealth. There are many questions surrounding this, and there are different rules that apply based upon which payer you're talking about. CMS has established guidelines for 3 different levels of care with telehealth, the first of which requires an audiovisual connection, meaning both sight and sound. The second can be performed just by phone, and the third can be handled through your portal. Bottom line is, all of the providers are working together to establish policies to keep our offices whole. The intention is to reimburse our practices at a rate similar to face-to-face visits. Now, I know you're probably thinking, well, I don't have a telehealth system in place. What can I do? The California Medical Association has a website, and we're going to give that to you later, that offers some telehealth options for certified HIPAA-compliant systems. On the other hand, if you choose to immediately begin telehealth, which is what I am recommending, you can use software as simple as Apple FaceTime, Facebook Messenger video chat, Google Hangouts, or Skype. And I'm pleased to tell you that if communication software is not available based upon the nature of the patient, their lack of a smartphone or tablet, it is best to proceed with just a phone. And even CMS is willing to reimburse based upon what they describe as virtual check-ins. One breakthrough that we've received today is that while CMS relaxed HIPAA regulations to facilitate care during the pandemic, we had not heard from the state of California. This evening, we learned that the state of California is on board as well. The goal here is to enable us to take care of as many patients as possible. So if you have a full-fledged telehealth system, then we should certainly use it. If you don't have a standardized HIPAA-compliant telehealth system, you can use these particular applications. If the patient does not have access to the technology, you should revert to using the phone. And we are providing the guidance for you in an appendix that is available on this website that'll key you into the provisions that have been established by Medicare in terms of telehealth, virtual check-ins, and e-visits using your portal, guidance for Medi-Cal and for commercial plans, as well as the latest HIPAA regulations. I can't emphasize enough that one of our key objectives is not only caring for our patients, but also ensuring the safety and health of your staff. I'm aware of one practice in California where 1 out of 10 providers in the practice with 40 employees tested positive for COVID, and they shut down the entire practice. Based upon our best estimations, we believe that in the course of the next 10 to 20 days, we're going to hit the surge or the peak in the number of cases. We need you and your staff healthy so that when we hit that surge, we can be providing care for our patients. By accepting the responsibility to care for those who entrust their lives with you, you must feel obligated to try to keep your office as safe as possible. Bottom line here is that pre-symptomatic transmission is considerable. Any person that we face on the street potentially has been infected with COVID. Our bottom line is that we need to extend a level of unprecedented vigilance at this stage in order to keep our healthcare system functioning and to sustain our ability to provide care. Now, if you're saying to yourself, my patient has a fever and difficulty breathing, so we should bring them in and see them in the office, my personal recommendation is that you do not do it. You send that person to the triage center at the local hospital. Again, Your decision is going to be based on your judgment, your experience, and your desire to ensure the safety not only of your patients, but also of the people who support your practice. Documenting care is clearly critical. A lot of people have asked me whether or not we need a signed written consent for telehealth. Bottom line is you do not. However, when you dictate your note, you must begin by stating that you received verbal consent from the patient to proceed with a telehealth consult. Now, some people have asked earlier today whether or not you can initiate that consult. Technically not, but in reality, you actually can. You can have your office contact a patient, see how they're doing, provide some educational suggestions, and upon hearing that your patient is symptomatic, that call can be relayed to you and converted into a telehealth visit. Again, you must use your judgment to determine the level of care that's going to be provided to this patient. I'd also like to tell you that we are working diligently on solutions that can be used at the community level to utilize our resources in the best possible way. And this requires thinking out of the box. It also means that hospitals, urgent care centers, long-term care centers, surgery centers have to find ways to work together. It's altogether possible in a community that a surgery center would be dedicated just to labor and delivery. An urgent care center may be dedicated to closed fractures. Another surgery center, outpatient center, could be utilized for non-elective surgeries that can be performed on an outpatient basis. But we must think of ways that we can work together, maximize the use of our available PPEs, and deliver the best care possible. The only way to stay on top of this is to check the websites that we're going to show you on a regular basis and realize that the information is changing on a daily basis. Finally, I'd like to say that the California Department of Managed Healthcare is working diligently to ensure that providers are whole. They're highly recommending telehealth services, and they have acknowledged that they will pay at the same rate as a face-to-face visit, not only for telehealth, but for care provided during a phone visit. Now, you're probably asking yourself, does that apply only to my COVID patients? The answer is no. The routine patients that you would normally see in your office at this time should be seen through telehealth. I was on the phone with a large university hospital earlier today, and just in the last few days, they've converted more than 50% of their visits to telehealth, and they are specialty oriented. Bottom line here is we cannot pigeonhole all of the needs, all of our patients into specific categories easily. So therefore, we depend on your judgment and your experience. Finally, we'd like to present a number of resources that you can check. Our team has worked exhaustively over the course of the last week to provide practice tools and resources that you can see. CMA is also working diligently to provide tools and resources that can aid you in care delivery and decision making, and the AMA has done the same. We have elected to provide additional support through our organization. We can help you with COVID testing, office workflows. I will personally help practices in that manner. We can also assist with questions related to coding and billing, and providing additional financial support to keep your practice open. We also have a program for sick leave and emergency family medical leave, and we can provide answers to most of your questions. If we cannot do so, we will get those answers for you or direct you to the right organization. I highly recommend that if you're not on Manifest MedX, that you consider working closely with them for the updates, the information, and the population health data that they will be able to supply you about your patients and your practice. And finally, you can request a copy of this presentation by emailing membership@rcmadocs.org. Before I close, I'd like to emphasize that we do not have all of the answers, but we certainly have a logical, practical approach. With the goals of sustaining care in our region and keeping your offices healthy so that you can continue to provide that care, I highly recommend that you review this presentation and consider implementing this strategy in your office tomorrow. And at this point, I'm delighted to take questions. Dolores?
Sorry, I hadn't unmuted myself. So we will be answering questions based on the questions submitted via chat at the little bubble at the bottom of your screen to be able to submit a question. The first question, we are offering televisits to all our patients. A few decline and want to come to the office. What should we do?
My recommendation is you use your best judgment, but I would not take care of patients in the office, especially for routine purposes. You may choose to make exceptions, but use your best judgment. You're jeopardizing the health of your providers and your staff.
What do we do if new patients don't have an email to fill out their forms? Can we still do a televisit?
Email is not necessary for a televisit. You do not need a signed waiver or a signature to be able to proceed with the telehealth visit. You should, however, document that you received verbal approval from the patient to proceed.
I'm billing maternity, antenatal, initial, prenatal, and postpartum. How do we bill Z codes via telehealth? Or what if we have a maternity patient with COVID-19?
I think those are excellent questions, and I'm not an expert on billing, but you can contact our coding and billing area for additional information, or better yet, I would recommend contacting your certification academy, which I'm certain has recommendations for billing and service lines at this point. There will probably be opportunities to set up labor and delivery areas in communities. You should speak with your hospital and look at the available services. However, you have to use your medical judgment in determining whether or not you're going to expose you and your staff for seeing that patient. My recommendation is that you work together with your local hospital, develop a strategy for seeing these patients, and share that responsibility.
We have patients that are scheduled for well child visits. Do you recommend that we cancel those visits?
My recommendation personally is that you do not schedule or see any well visits at this time. Again, for routine care, my recommendation is that you use telehealth exclusively. However, I've recommended in the past and will continue to do so that you check with the American Academy of Pediatrics and your payers to find the best strategies to deal with these particular issues.
Same line, but with immunizations. What do we do with a persistent mother who wants their child vaccinated during this time?
Again, that's going to require a great deal of judgment and expertise. There are certain vaccinations, as you know, that have to be delivered in a timely manner. Use your experience to determine whether or not you can safely provide that vaccination at that time, face-to-face.
What documentation guidelines are there for televisits?
The guidelines are consistent with your standard documentation practices for face-to-face visits, with the exception of stating upfront that the patient gave you their verbal approval to proceed with the visit.
We are a specialty office and need to do some procedures in the office. What do you recommend?
My recommendation is that any procedure that's elective that can be avoided at this time, to not perform those procedures. However, if the procedure is absolutely necessary, you should use your medical judgment and discretion to determine whether or not you wish to proceed.
Do we still collect co-pays for telehealth visits?
This is a really good question. I'm sorry that I didn't mention it, but CMS has stated that they are relaxing the requirement to collect co-payments for telehealth visits during the course of this emergency period.
Do we have to record these visits?
Absolutely not. There is no indication through the regulations that the visits have to be recorded. However, they do have to be documented in accordance with the recommendations that I provided previously.
How do we handle patient requests for off-work leave due to higher risk status of getting exposed to COVID at work?
I think that's a difficult one, and this question has come up multiple times. I think that if you wish to keep a patient away from work, you're going to need some absolute proof that the patient has been exposed and test positive for COVID. If a patient decides that they don't wish to go to work because they don't want to be exposed, if they don't have any predisposing condition, it's between them and their employer. I believe that the law states at this time that no employer can force the person to go to work. I would, however, check with your local organizations and determine whether or not this holds true for all of the employers in your region. Again, please contact our office for additional support in this area.
Any medical logic in using hydrochloroquine and Z-Pak in suspected patients?
Yeah, there are a lot of claims right now that hydroxychloroquine has some benefit. Because of a statement made by the president, there's sort of been a run on the pharmaceutical companies and their organizations, and believe it or not, practices that are hoarding the medication. From what we know at this point, and the jury is not in, there is no substantive proof that this absolutely works. However, I can tell you that there are more than 100 teams working on treatment modalities using existing medications at this time to effectively treat COVID-positive patients. I think we're going to learn more as the time progresses.
Are only medical-related visits billable? How about health education by RNs?
I'm not sure about health education. However, included in telehealth are individuals, providers who provide psychological and other services. So you would have to check with your health plan to determine whether or not they would cover the service. My belief is that if the service is necessary and it was performed by a person certified to provide that service in the past, that they, in fact, would likely pay for that service. You should, however, check.
How can we hide our physician's personal cell phone number from patients?
I believe that there's a sequence of numbers. Our staff is checking on this now, but if you contact us tomorrow, I believe there is a code that you can type in that prevents the person you are calling from seeing your cell phone number. You can also contact your carrier, whether it be Verizon or Cell One, any organization, and they can give you instructions on how to do it.
What would be the code to use CPT for new patients' telehealth encounters? The CPT codes we receive from insurances are for established patients.
Yes, that's a great question, and I want to thank the person for asking. Of course, these codes are set up for established patients, but I'd like to read something to you directly from CMS regs. It states, quote, to the extent that 1135 waiver requires an established relationship, HHS will not conduct, let me repeat that, HHS will not conduct audits to ensure that such a prior relationship existed for claims submitted during this public health emergency. My recommendation personally is that you do not turn anyone away, whether they've had a pre-existing relationship or not. HHS is not going to perform an audit.
We have been directed to use O2 for point of service and use modifier 95 by numerous insurance companies for teletherapy. We have, however, had claims rejected due to the service location. What is the service address we should be using?
The service address that you should use is your office, even though your providers will likely be providing that consult from their homes.
If we don't collect the copay, will the insurance companies pay the copay?
That I can't answer. That's going to be dependent on the individual health plan.
Okay. All right. We will also do some research on that, RCMA will. What about pain management prescriptions and visits?
There has been a sense throughout the country that during this period, patients are going to need pain medications. My feeling is you should use them judiciously. However, there is no intent by CMS or payers to deprive patients of medication that they need during this period.
Do we need to do physicals for telehealth such as skin, throat, and leg edema?
I think that telehealth is going to be limited without monitoring equipment inside the person's home. I don't think you should document a comprehensive physical examination if you cannot physically perform it. My recommendation is you be absolutely honest in your documentation and your coding. You state exactly what you did and what your recommendations are, and based upon what we are hearing across the board from payers, you will be paid.
Can we see first-time patients through telemedicine or only established patients? Also, can we prescribe benzos?
The first one I've addressed already. You can see patients without prior relationship with your practice. On the prescription of benzos, I can't answer that. That's going to depend on your payer.
Okay. I was asking for FaceTime video calls or Skype calls. Does my number show up? You would have to test that is what I would suggest within your staff before you do that.
I agree.
What policies are in place for pregnant staff members in the office who are in contact with patients face-to-face?
My recommendation is that you should have no pregnant staff members face-to-face with any patients at this time, in view of our recommendations for social distancing and the potential for that person developing the actual viral disease.
Okay. Dr. Bittman, that is all of the questions that have been submitted.
Thank you, Dolores. Was there one more?
Yes. Are prior authorizations needed for telehealth visits?
Prior authorizations are not needed for telehealth. And let me emphasize again that CMS is going to be lenient in the context of collecting copays. Prior relationships are not absolutely necessary based upon the fact that CMS is stating that they will not perform audits. However, whenever in doubt, please check with your other health plans. Okay. Let me take this time to thank all of you for listening in and participating. Your questions were great. I'm sure there'll be additional questions in the future, and know that our staff is prepared to either answer or get the answers for you. We appreciate your approach, and we want to make sure that you remain our frontline providers and that your staff remains healthy. If you have any questions in the future, please don't hesitate to contact us. On behalf of Dolores Green, who's done a monumental job in putting all of this together, and our staff at IEFMC, our CMA, I'd like to thank everyone, and I wish you the best of health.